And the first keynote lectures will be given by Professor Jaap Harlaar, and it is my great pleasure and great honor to introduce him. Professor Harlaar is an engineer, but he's working on the borders of the two fields, technology or engineering and medicine. He is a specialist in human movement science. He's working at the Free University of Amsterdam, but it's also connected with the that university. And he's specialist in musculoskeletal modeling. In Gait analysis, he was president and was co-founder of that Flemish Society for Clinical Movement Analysis. He is a long-time member of European Society for Movement Analysis of Adults and Children, and he was also president of this society. He is author and co-author of over 200 scientific papers, and I had the pleasure to know him for many years, and we met when he, together with Professor Jules Becher, came several times to Poland to introduce an interdisciplinary approach towards diagnosis, rehabilitation, and treatment of children with cerebral palsy, which was at that time a completely new concept in our country. So we are all grateful to him and to the Van der Fons Foundation, which sponsored their trips. So it was really a great pleasure for me to be able to be part of this project and to learn a lot. And really, I hope that we all enjoy Jaap's lecture, which is entitled Technology for Assessment and Therapy in Pediatric Rehabilitation. Please, Jaap, start.
Thank you very much, Margareta. I'll first try to get on my screen. I hope you can see the screen right now. Is that okay? Yes, okay. Margareta, thank you very much for your nice words. I also remember my visits to Poland very well. The hospitality we met. It's really a shame that I can't be like all of us in Poznan right now. But I hope this online will compensate for it a little bit. But nevertheless, I say dzień dobry, which means, for those who don't speak Polish, good day to you all. I also have to thank, of course, the organization of the European Academy of Childhood Disability this year to invite me for this lecture. I'm very honored to present to you some of my work that I did with my collaborators into the assessment and therapy in pediatric rehabilitation. I'm now affiliated to a range of universities to bridge the gap between technology and medicine in general, and that has been part of my whole professional life. But most of the things that I started is in the Department of Rehabilitation Medicine, or what's now called Amsterdam UMC, to develop clinical gait analysis. And clinical gait analysis, especially applied for children with cerebral palsy, has been developed over the last decennia quite a lot, thanks to technology, but also thanks to the intensive collaboration between engineers and clinicians who need to profit from that work. And doing so, I established a laboratory for clinical gait analysis, as well as a instrumented treadmill-based clinical gait analysis, together with virtual reality. And I will go into my co-workers, because this wouldn't have been possible without intensive collaboration. And although there were many of them that I worked with, I like to mention a few of them, which is currently Professor Annemieke Buizer and previously Professor Jules Becher, both pediatric physiatrists. Marjolein van der Krocht is following up on me in Amsterdam UMC. And from the many other co-workers, I also like to mention Dr. Adam Booth and Helga Haberfehler, who were PhD students at the time, and I will show some of their work in this presentation as well. This is the cover of my PhD thesis, and as you can read, it mentions both technology and it mentions rehabilitation medicine, clinical practice of rehabilitation medicine. And this is what I did, as I already said, most of my professional life. And in order to develop technology that's really clinically meaningful, there must be a way to gap the distance between clinicians and engineers. And a way to do it is not just gap it physically, but also mentally. And mentally, I mean that the two disciplines that are so wide apart in their expertise and in their way of thinking and their conceptualization should get to know each other's way of thinking. And this exchange really means that you can develop successful technologies that are eventually clinically useful. Going back to gait analysis, here you see a photograph of our lab in Amsterdam. And what we do there is measuring the gait of people, of patients. And why do we do that? Not just for the sake of measuring, which unfortunately happens a lot in with engineers at least, and sometimes also in clinical practice. But the specific aim of this was to develop clinical gait analysis as a means to inform the clinicians to decide on the most optimal intervention to promote the walking capacities of children with cerebral palsy. So the mission of our lab was to make people walk better. And you see a fairly old video here, deliberately, with all the wires and all the sensors that we used. Fortunately, we got rid of all those wires these days. And as you can clearly see, this young woman is walking in a kind of crouch, and if we're not going to treat her, she will end up in a wheelchair, and that's something we want to prevent. So motion capture is one of the bases of gait analysis. We see people walk, and the comprehension of movement is the first that occurs to us, is the first source of information to understand why people have difficulties walking. And of course, we want to measure it, to express it objectively and quantitatively. And we use this motion capture system, which is based on optoelectronic registration of markers that are sticked onto the skin of the body, and you can see this. But we must realize that although the equipment, especially over the last decades, has become very accurate and precise, it still measures the markers that are on the skin. And the skin can move to some extent with respect to the underlying bones. And how to use this information that comes from the marker systems. Well, you can see here what comes out of that. It's a bunch of graphs, and engineers love it. In fact, they've written the software that created those motion captures into this actual bunch of graphs. And please realize this is only one sheet. This is only one sheet of the kinematics, which means the movement of one leg. And each column is a plane, and each row is an anatomical level. So the anatomical levels range from the trunk to the foot, and the planes are sagittal, frontal, and transversal. If we make it a little bit bigger, you can see that the movement of this child, and we specifically focus on the knee in the sagittal plane, is expressed as a percentage of the gait cycle. And in between red is the normal course of the kinematics of the knee joint angle. And in blue, you see the 4 strides that were measured for this child. And you can clearly see that that he walks with a knee in flexion and it stays in flexion. Too much flexion in the stance phase and too little flexion in the swing phase. Well, this was already kind of obvious from the video, you might say, and that's indeed, you wonder why you need such specific information to measure the kinematics. Because even though we used all the information was presented by the engineers in a way that is most familiar to clinicians, and it relates to the definitions that are used and are known and are decided on based on physical examination, it still is a lot of information to comprehend. And what you want to get out of that is eventually, as I already mentioned, is apply some clinical reasoning to decide on the best optimal treatment. And you see a whole series of treatments here for children with cerebral palsy. And in order to make some relation between all the graphs that you see and the treatment decision, we first should break down this clinical reasoning process, I'd rather say, to a certain extent. We use the International Classification of Functions that you're all familiar to, but we will focus on the relation between structures, functions, so the impairment level, and the activity level. The activity is clearer, it's gait, and it's how well people can walk. As I said, the aim is to make people walk better. And the goal of clinical gait analysis is to find out, to identify, or to decompose which impairments in specific is responsible for any limitations on that activity or any restraint on that. All right, so it means that from a simple scheme, do a gait assessment and decide on an intervention, we need to consider that at 2 levels, 2 nested levels actually. First of all, we need to consider the ambulation, which is very close to what is important to the patient, and decide on that whether we're going to analyze using gait analysis whether there might be some specific interventions needed, whether there will be specific impairments that can be treated with a specific intervention that are responsible for the lack of performance on their ambulation. So at the end, our first concern is to evaluate the result of a specific intervention at the level that is meaningful to the patient. Secondly, we can also look with our gait analysis whether we indeed have reached that goal by targeting the right impairment. Some outcome measures related to those 2 levels. It's first like energy goals, walking speed, activity monitoring, everything that's important to the patients. And when we go to gait analysis, we take the glasses of the biomechanist and looking at kinematics, kinetics, and also the neurological level, how the muscles are coordinated. And the big thing, of course, is the right question mark. How come from this information to a specific intervention? And a specific intervention, for instance, an ankle foot orthosis. Detailing this nested scheme a little bit, you see here that the clinical reasoning, which is central, which is informed by all the results from the gait analysis, but also by the physical exam, might give rise to identifying specific impairments and each of those will lead to a certain treatment. And please note that no treatment at impairment level should also be an option here. And again, there are the 2 levels of feedback. My colleagues, Annemieke Buizer and Marjolein van der Krocht has worked this out because it's a very complex reasoning into something called Gait script to do some alternative or differential diagnosis kind of exercise and trying to find out in going back and forth between alternative explanations to identify impairments. being informed not just by the graphs, so the biomechanical view, but also by the physical examination here on your right-hand side, but also by means of the EMGs. And all those should come together like parts of the puzzle to identify the part that isn't fitting and we should try to come up with an intervention to make it fit better. One of the things is that all this information is pretty hard to comprehend, as I already said, the whole bunch of graphs. And therefore, one of my things that I worked on was, can we make all that complex information more intuitively accessible for clinicians, for people who work with children, but also with adults who have walking problems all today. And one way is to use digital video. This might seem obvious these days, but 20, 15 years ago, when we started all this, or in fact we started even earlier, digital video was pretty rare. And digital video is very powerful in it's especially these days, current technology. It's pretty simple, but it's still very powerful. And if you extend this with what we call the screen-based goniometer, you can mark specific points during the gait cycle that are important and do a more precise measurement instead of trying to comprehend all the kinematic information that comes out of a motion capture system. In an animation, this looks like, you can see it, you can use a frame-by-frame analysis using a dual plane video, either one video stream with a split screen or a dual screen. And we developed a goniometer which looks like a stick figure, and you can simply align it to the video. And then on your left-hand side, you can read out easily all the joint angles that you're interested in at this specific point in time. And of course, you can do it over and over again, and it really enhances the observation of gait very, very, very much. But apart from the kinematics, there's also the kinetics that are informative. And kinetics are basically measured starting with the ground reaction force, using a force plate, and a force plate is a super advanced version of the bathroom scale, and it measures the amount of forces that are put on the ground. And when measured in conjunction with the motion capture system, the biomechanical models we use can easily come up with something that's called a net joint moment. And a net joint moment means the amount of internal muscle contraction that is needed to maintain that posture during the gait in a freezed version of that single frame. And it's not just the amount of force that's on the force plate, but especially it are also the lever arms. As you can see here, the length of the ground reaction force is by the purple arrow, and the lever arms are established by the distance between the ground reaction force and the point of rotation of that joint, and that makes up the net joint moment, here expressed in a simple equation. And from the right-hand drawing, you can also see that although the ground reaction force can be equal in the two situations, when the lever arms are very, very short or even zero, it will take no muscular effort at all to maintain that position. So this is a very, very intuitive way to estimate the load on the muscles. And so we decided to actually use that approach to visualize it directly into the video screen. You can see the time course of the ground reaction force in yellow on the lower part, but what's more important is the actual projection of the ground reaction force in the upper part. And again, here's a little animation that shows how easily it works, and you can go frame by frame and inspect how the ground reaction force changes and how it overlays the body. And when relating it to the joint centers, it's a direct estimation of what the load on the muscles is to be able to maintain that position. And again, this is a very simple, intuitive, and powerful tool to inform clinical decision making. It's not super quantitative though, that's also true. All right, the next thing is that we want to relate that net joint moments to actually load of the muscles. But there's another problem. This is a biomechanical problem that one should realize, because, for instance, if you look at the net joint moments around the knee, you might think this directly predicts the amount of force that is needed by means of the quadriceps, which makes sense to a certain extent. But on the other hand, there are multiple muscles are part of the quadriceps, and which part is taken by which muscle. But also there are endogenous muscles active, for instance, the hamstrings and the gastrocnemius, that also cross the knee. So there are a multiple amount of muscles that make up that net joint moment. So to identify the precise contribution of each muscle is not straightforward. Fortunately, we have another way of informing us, and that's the electromyogram during Gait. The electromyogram, also the technology there is today, we can, this is still a picture with the wire, but we can use wireless EMG sensors these days. And if we translate that by means of some signal processing into its envelope, we can relate the instantaneous activity of the muscle again to the phase of Gait in this viewer. And again, here you see in the lower part of the plane how the three selected muscles are active to make this movement happen. Or in other words, what kind of neurological signals are sent to the muscles to make easy way. It's not precisely, it doesn't quantify, I'd rather say, the isometric force, but at least it gives a reasonable estimate of how active the muscle is. And putting all this together, we can put this into our, and we inform our clinical reasoning. But having said that, you still realize that all of this information is still pretty hard to comprehend. You need a laboratory, you need also a skilled staff and a skilled rehab team to get enough expertise to do all this kind of reasoning. And in the last few years, artificial intelligence is a kind of hype, and you wonder whether artificial intelligence as a new technological development could also help us in deciding what kind of treatment people should get. Well, there is good news, because the algorithms that are based on artificial intelligence or machine learning are so super advanced these days that they do a really good job. Here you see markerless motion tracking based on ordinary video, one based on a software package called DeepLab Cut, and the other one is called OpenPose. So you see they both perform not super accurately. If you look closely, they every now and then they miss something and they seem to be off. But as time will progress, I'm pretty certain that we will get rid of marker-based motion capture systems in some time. But there's even better news, because very recently in August in Nature, our colleagues from the United States have published an article. It was a combined article between Minneapolis and Stanford, that besides the traditional way, as you can see here on your upper hand side, now I have to wave here to activate my lightning. You can see here the traditional workflow with a lot of expert analysis as part of it to come up with the report. Now you can take a single camera video, do the kinematic identification as I just showed you, then put that into a neural network to come up with a report. And based on the evaluation, this kind of prediction model, this is a prediction model for a single event multi-level surgery in children with cerebral palsy. The performance of this network outperforms the predictions that were done based on traditional or conventional marker-based system. So I think there is a great future ahead if this kind of technology further develops to assist clinical decision making in this kind of complex situations. And not only for walking, because my colleague Helga Haberfehler also developed a package that was used for dystonia assessment. And here you can see that for a much less predictable movement as the spontaneous movement in dystonia, the software is able to track it. And the goal of our project, and maybe some people have seen a presentation this afternoon, is to come up with a model that can be trained in order to automatically and reliably distinguish between dystonia and chorioathetosis. And not only that, but also make it possible, for instance, for the parents to use their smartphone to make this kind of videos, which will be very convenient for the care of these children, and at the same time inform clinicians in the best optimal way to decide on their treatments. From gait analysis or movement analysis I just showed you, I want to briefly touch on gait training. Gait training is one of the things you can do, and especially with a advanced setup. On the right hand side, what you see is a treadmill. It's a dual belt treadmill which is instrumented, meaning that there are force plates underneath each belt. There's a motion capture system, and there's also a virtual reality environment, which makes it possible to feed back all kind of information, not only sceneries, but also the information that's actually measured onto the screen to interact with the gait of the patient. And when we go to what we call functional training, is to actively practice walking, improve walking ability. And again, we're looking at the relation between structure and activity. And our idea was to come up with some targeted practicing of walking. And my colleague Adam Booth, he started with a systematic review demonstrating there is a great potential for gait training, and because it was so promising, we decided to develop based on the system that we showed. It's the Grail system. It's an instrumented treadmill, as you can see. And what was fed back to the patients. This is the big cylinder you see on the foot of the avatar that's projected on the screen, is the amount of push-off that is used, because a lack of push-off is often a cause of limited walking performance. And in this way, by putting this in a more or less entertaining game, children can practice and increase their score while training on gait, but focusing on a specific impairment that has been identified as being the limited factor. Here you see a baseline movement when the focus was on to increase step length, and here you can see the post-training results. And you can see that the training was now done with different kind of avatar, with projected feet onto the ground that had to be touched, and you can see an immediate effect on this parameter that has been trained, that was present. So with this kind of biofeedback, we were able to train children with cerebral palsy and increase the step length also increased knee extension, and also increased their ankle power generation at push-off. That was the three modalities we used, and we identified, of course, first which modality was needed for that specific patient. And what we found is that they increased on all those aspects, but actually it did not generalize to overall performance across the group. So the idea was that, so that again focuses on the question, what exactly is the relation between those identified impairments by gait analysis related to their overall gait performance? It's not straightforward that whenever you improve some identified impairment that was measured using gait analysis during gait, it automatically generalizes towards better performance as perceived by the patient himself. So this is, yes, here it is. So the targeted knee training, after some analysis, we came to the conclusion that we did only a short-term training, and we really like to extend this to a long-term training to see whether this kind of targeted training that has effect and has potential, whether it generalizes to an actual overall improvement on overall gait measures. And a technological way to do that is, for instance, to use sensors, inertial sensors that don't need a camera system, that can be used almost everywhere. On your right-hand side, you see here such a sensor on the foot, together with a marker system in this case to look at concurrent fluidity. But you can place the markers everywhere on the body, and if you use a HoloLens, that would be a means to feedback the information as we just saw on the screen in a very extensive and comprehensive setup. But many of these, and also of course a biomechanical model, can be fed using those inertial sensors. It would be a great way to do this targeted gait training in an ambulant way and see whether children on a large scale intervention can profit from that. This is my concluding slide. I hope to have shown you that you can use technology for assessment and therapy in the pediatric rehabilitation. There are lots of opportunities. There's also lots of technology that might not be reachable for every center, but current technological developments are in a way that I'm sure it will be accessible on a relatively short term. So my advice to you is to really embrace all of these technological developments, but don't embrace it as it is, but develop it yourself in close collaboration between clinicians and engineers, and apply, of course, it wisely, because in the end, it's the patient that should profit from it. Technology is a great tool, but again, apply it wisely. Thank you very much.
Thank you very much, Jaap, for the inspiring and interesting presentation. I had I had one question, so I will start and then give the word to Mr. Sullivan. I was thinking about the inertial sensors. Do you think that maybe this technology can later on assist us with similar situation we are facing now, when many children are cut off from the rehabilitation facilities and have to be trained by family members at home? Maybe this is the future for such situations where you can borrow such a suit for the future, and maybe it can be a help in such difficult situation. Thank you.
Yes, I think so. Also the inertial sensors becoming cheaper and cheaper, and there are even some developments that are still in the laboratory to use so-called smart textiles, meaning that all the sensors are integrated into the trousers, for instance. And this would mean that this kind of kinematic information, when connected to a smartphone or another means, can be used at home. And if it also communicates with the clinician in the center, many miles apart, away from home, the parents and the patient can get specific instruction on how to improve their therapy and to see whether the patient is improving or should adapt the therapy and so on and so on. Yeah.
Thank you, Jaap, for this very nice talk. Actually, I'm the chair of the next session, but
okay.
I'm here, so it appears that I have to ask a question.
All right, Sofian, and not to
which is my pleasure.
Yeah.
So, yeah, definitely there is a question between what we can do in a lab, what we can measure in a lab, and what's real life. Do you think that the technology really would help in developing real life measures and how it will maybe change our assessment in general, your vision about it in general?
Yes, I think this ambulant way of measuring will probably contribute to making assessment that relate more to the practical, the actual activities of children. At the other end, you should also be very careful to interpret those measures, because it's done in a non-controlled environment. So whenever a child is, for instance, walking in a different way, it might be just because of the surface that he or she is walking on requires so. So there is a great advantage of this ambulant measures, but there is also a pitfall, and I think the combination of measuring at home and in the laboratory, serving different kind of questions, would be the ideal situation. Yep.
Thank you for a very wise response.
No further questions, or?
There is one question from the audience. I was wondering what your thoughts are on the use of upper limb kinematics technology with respect to feasibility, future, and perspectives.
Yes, I didn't touch on upper limb. Actually, I have been active in developing a marker model for upper limb, and also applied it in children with cerebral palsy. The point is that the activities related to the upper limb has a huge variability. There's a great diversity of tasks you can do, and they're all in a more or less non-stereotyped measure way. So it's difficult to do so. Currently, we are developing an exoskeleton for children, for boys with Duchenne, to support their arms, to extend the possibilities to use it to beat the progressive weakness. And yes, indeed, we use inertial sensors on the arms right now to assess it. So technologically, it's certainly possible. It's just another way of applying all the technology to a different part of the body, but the interpretation is much different as opposed to, for instance, gait analysis.
There is another question connected with sensors. What are the most sensitive outcome measures on the evaluation with sensors? Do you have any suggestions using or not using?
The most sensitive information of sensors. Well, it really depends on the kind of question you would like to answer, of course. And as I tried to figure out, in the end, the bottom line is to decide on whether to apply treatment A or B or no therapy at all. So it really depends on that kind of if you have to decide on whether to use Botox or not, for instance, then EMG will be a very sensible way to see whether a muscle is active. But if you have to decide what kind of orthosis you need to do, then net joint moment around the ankle is very informative to inform you where the foot is loaded, and also the knees. So you will be able to decide what kind of orthosis, what kind of stiffness, etc. will be needed for that specific patients. So there's no overall answer. It really depends on the question, and this is of course very challenging. Asking the right questions is solving half of the problem.
Okay, we have maybe time for the last question. What you advise, or what would be needed to ensure these new technologies also available in less resourceful countries?
Yes, that is as I tried to explain. We have been making efforts to do so. I think what is needed, that we focus on technologies that are widely available. We will focus on again on the problems that are most prevalent, that need to be solved. So it really involves the people who are going to apply it to ask the right questions, referring back to what I previously said, and then we can develop specific technologies. And technology is there. Also relatively cheap technologies, but we must be sure to develop it in the right way so that the people who are going to use it to their profit, and not just to have another measurement instrument. And I think the high-income countries can help a lot to help to find out what makes sense and what doesn't make sense, because sometimes you only can conclude that after, for instance, some research. It's not known at beforehand. So a good collaboration, especially between technicians and end users, and especially the end users in those low-income countries, is critical to develop meaningful technology.
Thank you, Jaap. We are moving to the next presentation. Silva, please, floor is yours.
Thank you very much for all the attendees for attending this lecture, and thank you very much, Markerless, for sharing this.